Okay, thank you for your reminder. So today we're going to discuss about oropharyngeal and esophageal candidiasis. So remember, this type of candidiasis are very common in immunocompromised patients, mostly in HIV patients. So most of the time, you will encounter those kind of opportunistic infection even in HIV infection. But HIV is not the only condition that can increase the risk of this candida infection. But as I mentioned in the previous lesson, candida is or candida species are a normal flora, especially the albicans is a normal flora in the oral cavity. So when they get opportunity to grow, that is, they become actually infectious and actually causes ulceration in the mucous membrane of the oral cavity, as well as sometimes even it go down to the esophagus. So let's see first oropharyngeal candidiasis. It is known as oral thrush. So this is a common and localized infection of the oral mucosa, mostly caused by a yeast known as Candida. So most of the time, in case of oral thrush, this is how the patient presents with. You will see a whitish appearance in the mouth, especially in the tongue. So this appearance is actually a very typical features of oral candidiasis. So when you see candidial infection in the oral cavity in a patient, by the way, you have to check the immune system. So most likely, it is very common in immunocompromised patients. You have to even do further investigation to rule out other causes such as HIV, cancer, DM, and etc. Then, as I mentioned before, Candida albicans are a common commensal organism, and it is the most frequent infecting species of the oral cavity. And as I said, it can also called candidiasis. Anyways, this oropharyngeal candidiasis or oral thrush can actually even extend to the esophagus and causes a more severe infection known as esophageal candidiasis, as you can see from the diagram. So like you'll see an infection in the esophagus. So by then it is very hard to clinically investigate esophageal candidiasis, but most of the time they are supposed to look at with endoscopy to see whether there is actually like a whitish appearance in the lumen of the esophagus. So that is how they are going to like how they are going to conduct diagnose esophageal candidiasis. And as I mentioned before, this oral thrush is a common fungal infection and mostly associated with immune suppression. So it is mostly linked to immune suppression. But if you don't treat them, it can actually even progress to esophageal candidiasis. That is what I said before. Then, when you look at the epidemiology of the oropharyngeal and esophageal candidiasis, they are mostly indicators of immune suppression. So that means they start to overgrow when the immune system of the patient or the individual is usually declined. So it is often common in the extreme ages like infants, elderly, as well as immunocompromised patients. So like the infants are because the immune systems are not matured enough, the elderly is actually as a result of aging. So those are the commonly affected population group with this candida infection. So as I mentioned, this oral candidiasis is also very common, a common reported ADR by a patient receiving inhaled corticosteroids. So most of the time, like asthmatic patients, chronic obstructive pulmonary disease patient, most of the time they are going to use inhaled corticosteroids to prevent inflammatory reaction in the parenchyma of the lung. So that is why proper inhalation techniques are very, very key to prevent, by the way, the possibility of oral thrush in this patient population. So it is very common by this. So you have to give them proper instruction to the patient when they are taking inhaled corticosteroids, because they can actually even cause suppression of the immune system in the oral cavity, and ultimately it increases the risk of growth of Candida species. Because of that reason, the moment the patient normally administer the inhaled corticosteroids, they are supposed to drain their mouth adequately. Otherwise, there is high probability. And based on even epidemiological studies, oral candidiasis are a very common condition during inhaled corticosteroid users. Then the prevalence of esophageal candidiasis usually reaching 37% among patients with inhaled corticosteroids. You can actually even see the prevalence is significantly high. Then the incidence of esophageal candidiasis is highest among patients receiving high dose of corticosteroids or with ADM patient. This is related to the immune suppression of the individual. So this is the common population that is usually affected by this candida infection. Then, and as I said before, it is very common, like oral thrush is very common opportunistic infection in a patient with HIV. Okay, so in HIV infection, that is normally you are going to see most of the time. Candida infection is very common. That is why adherence to the antiretroviral treatment regimen is very key to prevent opportunistic infection such as oropharyngeal candidiasis and esophageal candidiasis in HIV infection. I think Dr. Larry is the one is going to take you through about infectious diseases. So most likely, I'm expecting he will take you through about the WHO staging of HIV infection. When do we actually expect oral candidiasis in HIV infection? So what will happen? What will be the stage when they develop oral thrush? What will be the stage when they develop esophageal candidiasis? We'll take you through. I'm expecting so. Okay, then the etiologies, Candida albicans still accounts like the highest percentage of cases of both oral thrush as well as esophageal candidiasis, but also the other non-Candidia albicans species are also responsible to cause a few cases of this oral candidiasis and esophageal candidiasis. And apart from that, in a patient with cancer, but they remember when a patient is actually having cancer, the immune system is actually suppressed. So still, you expect this condition in cancer patient, especially based on the epidemiological studies. The non-Candida albicans species accounts like for almost 50% of all Candida infection in cancer patients. So that is based on the epidemiological studies. Then having said this much, what are the possible risk factors for oropharyngeal and esophageal candidiasis? How does the patient will get this infection? So what are the risk factors? So extremes of age, as I mentioned before, extremes of ages are is susceptible for candida infection. Impaired mucosal integrity. If there is any breakage in the protective barrier, which is very common, specifically during surgery, during radiation therapy, during the normally mucositis as a result of chemotherapy in cancer patient, there is a possibility of breakage of this protective barrier. So if there is, and that is actually a good opportunity to increase the growth of this normal commensal in the oral cavity. Denture can also be there, dryness of mouth because reducing cleansing and defensive factor of saliva when there is dryness of mouth, xerostomia, and also use of antibiotics. I think even this one mentioned in the previous lesson. So use of broad spectrum antibiotics will actually distract the protective flora in the oral cavity and ultimately allows the overgrowth of pathogenic organism. Remember, like in the oral cavity or in the normal flora, we do have pathogenic and non-pathogenic organism. So under normal circumstances, the pathogenic organisms are under tonic inhibitions of those protective floras. However, when you start actually distracting the non-pathogenic microorganism, now the pathogenic organism will get an opportunity to grow and causes devastating or infection to the individual. So that is why antibiotic use is responsible to cause or increase risk of oropharyngeal candidiasis. So use of corticosteroids and use of immunosuppressants are as a result of suppression of the immune system, and also HIV infection is related to the immune system suppression. Nutritional deficiency is related to like alteration in the defense mechanism, and also DM is related to high elevated glucose level is actually a good environment for the growth of microorganism. By the way, that is why when a patient is actually having diabetes mellitus, they are more susceptible for urinary tract infection because the moment they are actually spilling a lot of sugar in the urine, remember, when sugar is beyond the capacity of the kidney to reabsorb in the renal tubule, now you will see sugar in the urine. So that actually we call it even glucosuria. So that is actually a good opportunity for the growth of even normal flora in the urinary tract. That is why having DM is a risk factor for urinary tract infection because UTI is usually very less common in men because the urethra is actually very large. Okay, so those are the possible risk factors of candida infection. So having said this much, now let me take you through about the pathogenesis of this condition. So normally oral trash occurs when the normal environment is altered. And most of the time, this oral infection is not like something that is acquired. Oral candidiasis is not something we can contract from other individual. We can actually contract, but most of the time is due to alteration of the normal flora of the oral cavity. And as I said before, Candida organisms frequently colonize the mucous membrane of the oral cavity, and these organisms will not become pathogenic until the environment is disturbed. So they are okay, they keep silent until the environment is actually what? Disturbed. So when there is actually any factor that affects this normal environment, like in the setting of broad spectrum antibiotics, in case of tissue damage, such as chemotherapy in cancer patient, trauma, hyposalivation, and immune deficiency, now this is a disturbed environment and they will try to use this opportunity to grow and ultimately causes infection. Yes, so this is how the pathogenesis of even oral, oral trash and esophageal candidiasis happens. Now, let's see about the clinical presentations of and diagnosis of oropharyngeal candidiasis. And most of the time, the diagnosis is a presumptive diagnosis, like that is based on the clinical presentation of the patient. And most of the physician, they will not conduct even any lab test because that is just like even wastage of resources for even for the patient as well as for the hospital. So there is no need to culture to diagnose oropharyngeal candidiasis because the symptoms are actually very typical and those whitish appearance in the oral cavities are very common. So most of the time, the diagnosis is a presumptive diagnosis. So what are the other clinical features of oral trash? you will see sometimes sore, and also as a result of the sore, they encounter a very painful mouth, and they also having a burning sensation on the tongue. And as a result of the sore, they do have difficulty in swallowing dysphagia. That is very, very common. And also, of course, metallic taste can actually happen. Then apart from that, you will see a diffuse erythema on the surface of the buccal mucosa, the throat, the tongue, and the gums. That is general erythema as a result of the irritation. And also you will see a white patches on the tongue. And most of the time, when you touch with a tongue depressor, it can be removed. Those patches can actually can be removed. So this is very typical for oral tracheitis. And sometimes you will see even angular cheilitis. You will see some kind of fissures at the corner of the mouth, at the angles of the mouth. That is also very common. And usually it is a cracking lesion. It's like those angular cheilitis can also be common in iron deficiency anemia, herpes zoster infection. So Larry will take you through. So those are also some of the symptoms you can actually even see from those patients. So as I said, the diagnosis is mostly presumptive diagnosis that is based on the clinical picture, but sometimes culture can also be done to identify the type of species like the patient is actually infected with. Otherwise, most of the diagnosis is based on the clinical presentation. Then let's see about the clinical presentation and diagnosis of esophageal candidiasis. So when a patient is having esophageal candidiasis, we might not see the whitish appearance because it is actually happened on the lower part of the mucous membrane, that is the esophagus. So, but most of the time, the patient can be febrile, but they also have difficulty in swallowing. Yeah, odonophagia means there is a pain in swallowing. Dysphagia means difficult in swallowing. So, and sometimes even you will see retrosternal pain, like there is a pain inside the breastbone. Remember, the breastbone is actually the midline that actually connects the ribs of the person or the human being or even any animals. So the patient usually complain the retrosternal pain, dysphagia, and odonophagia. Sometimes you can also see edematous whitish plaque, ulceration of the esophagus, increased mucosal permeability, and narration of the lumen. But those signs can also be all investigated under endoscopy. Otherwise, you cannot see esophageal ulceration without doing endoscopy. Is there anyone who carried out endoscopy before? Anyone? Upper GI endoscopy. Anyone who undergo this procedure? Okay. Okay, so when you look at the diagnostic testing, unlike the oropharyngeal candidiasis, diagnosis of esophageal candidiasis is not based solely on clinical presentation because we cannot actually even rely on, and there is a need of endoscopic visualization of the lesion and culture for confirmation. Yes. So due to the invasive nature of those procedure, most practitioners, they prefer actually even to treat the infection presumptively, like based on the clinical presentation of the patient. And sometimes endoscopic procedure is actually reserved for a patient who failed to therapy. So sometimes some patients, they are not willing even to undergo this procedure. It is not very comfortable procedure. Then apart from that, availability is also an issue. Like how many facilities normally conduct upper GI endoscopy. Because of that reason, most practitioners normally they treat the infection symptomatically. Okay, so generally this is how we are going to diagnose esophageal candidiasis. Okay, having said this much, now let us see about the treatment modalities of oropharyngeal candidiasis as well as esophageal candidiasis. So what is the goals of therapy? What is the goals of therapy? Our therapy goal will be to eliminate the clinical signs and symptoms of candida infection, which we call it clinical cure, avoid the progression of the disease to more extensive disease to prevent complication, and of course, if if this oropharyngeal candidiasis is not treated, it can actually even extend to the esophagus, causing esophageal candidiasis. So the goals of therapy is just to resolve the clinical features as well as to prevent the progression of the disease. Those are the goals of therapy for oropharyngeal candidiasis. Then, when we are treating this patient population, treatment should be individualized. And you have to consider the following condition when we are managing those conditions. So what are those conditions we are going to consider? Look at the immune status of the individual. That is very important. So if the immune system of the individual is compromised, maybe you have to extend the duration of treatment. Then look at the other concurrent mucosal and medical diseases and look at any concomitant medication and exogenous infection sources that can actually even exacerbate the condition. But most importantly, when we are talking about concomitant or comorbidities, we have to look at the HIV infection because in HIV infected patient, if the patient is not treated adequately, antifungal, like that means if the HIV infection is not treated adequately, now the antifungal treatment alone produces only a mild clinical response. And as a result, the relapse rate is usually very higher. So because of this reason, like adherence to HART or ART regimens are very important for better treatment outcome. That is expectation, by the way, when a patient is having HIV infection. Make sure the patient is actually taking effective, highly active antiretroviral treatment regimen. That is actually very, very important. Otherwise, antifungal treatment alone will not resolve the problem and the patient will actually come back with recurrent infection. Then, whenever possible, now it is good to minimize all predisposing factors, special administration of corticosteroids, chemotherapeutic agents, and antimicrobial agents, as well as we have to maintain proper oral hygiene. That is very key in the treatment. Otherwise, we are not able to achieve the desired treatment outcome. Okay, then, when a patient is actually having low risk, maybe if they are not using steroids, if they are not having any immune compromised condition, maybe topical agents are the first line therapy for management of oropharyngeal candidiasis. So we can actually even apply a topical antifungals at the site of the lesion. Then that is how we are going to treat at the first line management. So what are the first line topical agents? We are going to use the nystatin cream. We do have even the nystatin oral suspension. Also, we do have clotrimazole. Those are the most widely available drugs in the management of superficial fungal infection. Of course, if the patient is not responding to oral therapy now, that is when we are going to consider systemic therapy. So for mild infection, we can actually even give nystatin suspension 4 times per day. And also we can give clotrimazole troches like 10 milligram 5 times per day can also be given. However, when a patient is having moderate to severe cases, once daily oral fluconazole will be given. So most of the time, I think the 200 milligram strength of fluconazole is widely available. That is where we are supposed to give. But in case of refractory cases, now we are going to actually consider the broad spectrum antifungal medication like oral itraconazole 200 milligram, posaconazole 400 milligram, voriconazole 200 milligram twice daily, or amphotericin B suspension. However, these ones are actually considered, but it is not very easy to get those drugs even in the lower facility. I'm very sure cost-wise they are also a bit expensive, and also availability is an issue to get those broad spectrum antifungal medication. But amphotericin B is widely available, but because of toxicity issues, is not really commonly recommended, especially the conventional amphotericin B. What is the difference between the conventional amphotericin B and the liposomal amphotericin B? What is the difference?
The formulation.
Okay, like what is the difference in terms of formulation?
Okay, the liposomal one is in the form of a liposome, like the
Continue.
drug.
Okay, then, okay, good. So what will be like the benefit of having the liposomal formulation of amphotericin B? Okay, Betty? Betty Kimani? What is your opinion?
Yes, I'm not really sure.
Okay, but have you covered about amphotericin B antifungal medication, the pharmacology counterpart?
Yes.
Okay, good. Then Thomas,
Yes,
so what is your opinion? What is the importance of developing?
I'm not really sure.
Then Sharina Patel, you want to try?
Yeah, I want to try. Maybe
Okay.
it's because it can reduce the toxicity.
Yeah, that is actually the essence of, yeah, that is the essence of actually developing the liposomal amphotericin B. The conventional one is actually highly susceptible to cause toxicity. But Patel, what is the most common toxicity of amphotericin B?
Nephrotoxicity.
Nephrotoxicity. Any other?
Acute reactions.
Okay, there is a possibility of reaction. Any other in terms of electrolyte disturbance? But then for sure, if you actually
Thrombocytopenia, maybe.
okay, thrombocytopenia. There is one toxicity I'm looking for, which is very common in the clinical practice. Like when
Hypersensitivity.
hypersensitivity is not as such, but it can happen. That is why sometimes we have to give test dose. Any other? Electrolyte disturbance. There is one electrolyte disturbance which is very common with amphotericin B IV infusion. I don't know why. William, you want to try?
Hypokalemia.
Hypokalemia. Thank you so much, William. So how does it causes hypokalemia? How does amphotericin B causes hypokalemia?
It more potassium is lost in the kidney, in the renal tubules.
Yes, actually it causes, the principal mechanism is actually by promoting leakage of potassium from the kidney. Because remember amphotericin B, if you look at the mechanism of action, amphotericin B normally binds with the ricostrum, the cell membranes of the fungal, as well as the cell membrane of the human being. So when it binds, it forms actually a pore. So that pore normally allows leakage of electrolytes. That is why it can actually even cell less by leakage of important nutrients for the fungal growth and replication. So that is the principal mechanism. So when it binds with the renal tubule, that is why it actually causes renal toxicity. But as well, it actually promotes, like by forming that channel, it actually promotes the leakage of potassium. That is why hypokalemia is the most common side effects of amphotericin B. That is why, by the way, we'll discuss when we are discussing about cryptococcal meningitis, which is actually a fungal infection or a meningitis caused by a fungal organism. And most of the time, we usually give amphotericin B in the management. So when you give by the amphotericin B IV infusion, you have to give potassium chloride supplement. Otherwise, the patient will end up actually even hypokalemia. Remember the risk of hypokalemia. We'll discuss more when we are discussing about cardiovascular disorder. It can cause cardiac arrest or arrhythmias. Because of that reason, the moment you are actually giving amphotericin B, you have to monitor the serum potassium level as you administer potassium chloride supplement orally. Otherwise, you will kill the patient. So those are mandatory requirements when you give amphotericin B. I think the conventional one is widely available in the local market, but of course we also have the liposomal preparation because the liposomal ones are actually less affinity to bind with the kidney, and the toxicity is actually comparatively minimal as compared to the conventional one. Okay, good. Then those are the treatment approaches we are going to consider in case of refractory cases. Okay, then how do we treat for oral tracheitis in HIV infected individual, especially if the initial episode is adequately controlled with topical agents such as clotrimazole, tracheitis, as long as the symptoms are not severe and no esophagus are involved, maybe we can use topical clotrimazole even in HIV infected patients. So like when a patient is actually having maybe mild infection and the esophagus is not involved in even in HIV infection, we can use topical clotrimazole. Agents can also be used. So when you look at even in terms of response, the clinical response is equivalent to oral fluconazole and itraconazole solution. But because of, by the way, because of the cure rate is lower and the relapse rate is very high, most clinicians normally they don't use topical clotrimazole when they are managing oropharyngeal candidiasis in HIV infection. What is very common is normally the oral fluconazole. That is very easier. You know, they just normally give one tablet once per day. It's very easier even for the patient, you know, instead of applying like in the oral cavity. So the tablet is very easier to use. So that is why most clinicians normally prefers. Then what is the duration of treatment for the initial episode of oropharyngeal candidiasis? 7 to 14 days are usually sufficient. 7 to 14 days. So when a patient is having maybe oral thrush, you give them at least for 14 days of fluconazole, then that is all. Then you monitor. Yes. If there is a troch, clotrimazole troch like 10 milligram, you are going to hold one troch in mouth for 15 to 20 minutes. It's like a lozenge for a slow dissolution 5 times daily. Also, nystatin solution, 5 ml, you are going to rinse your mouth and swallow 4 times daily. Fluconazole, I think fluconazole is the most commonly used drug because of availability issues. Yeah, but the major problem with azole antifungal, most of the time, they usually cause GI upsets. They actually cause GI upsets. Sometimes nausea, vomiting, diarrhea. Those are actually the most common complaints when they are taking azole antifungals as a class. So fluconazole, 100 to 200 milligram daily dose. Yeah, you can give for 7 to 14 days to treat oral thrush. The saconazole is also available in the form of solution, oral solution, especially for pediatric population, or in the form of tablet, like 200 milligram tablet, once daily can be given. So still, itraconazole can cause GI upset, but not common. But most of azole antifungal, they do have some potential to cause inflammatory reaction to the liver and hepatotoxicity. Despite it is not common, you have to even check. Because of it causes hepatitis or inflammation of the liver. Then, apart from that, itraconazole. Itraconazole, when a patient is actually in itraconazole, it has negative inotropic activity. That means it can actually even reduce what? Contractility of the heart chamber. And as a result, it can actually even increase risk of congestive heart failure, pulmonary edema with long-term use because of negative inotropic activity. That is why when a patient is actually having underlying problem on the heart, saconazole will not be a drug of choice because it can worsen a condition. Remember, in heart failure, like the heart is not able to pump properly. Yes, if the heart is not able to pump properly, and if you give them itraconazole, and it actually first reduce contractibility of the heart, you're actually worsening the condition. Because of that reason, when a patient is taking itraconazole, you have to be very careful. Okay, then posaconazole is also from the newer antifungal agents. I'm not very sure about the availability of this medication in the local market, but still there is a possibility of hepatitis and the upset you are supposed to monitor. Okay, then in case of refractory cases, now you consider to give them for a minimum of like more than 2 weeks. You consider maybe for 3 weeks, maybe for 1 month. But generally speaking, the guideline recommends in case of refractory oral thrush, the patient is supposed to be treated for a minimum of duration of about 14 days. So with what? With broad spectrum antifungal medication. So remember, this is the list. This is actually like the possible options of treatment. So you are supposed to pick based on tolerability and based on the patient condition, then you can, and also cost, you have to look at it and you treat. But as I said, fluconazole is widely available. So we can still give itraconazole. Voriconazole can also be given. Then amphotericin B can be given, but this one is usually not commonly recommended because of nephrotoxicity, especially the conventional one. This one is the conventional one, by the way. The deoxycholate formulation is the conventional amphotericin B. So these are the doses, and of course you are supposed to give potassium chloride supplement to prevent this electrolyte disturbance. The echinocandin, like the caspofungin, the fungin echinocandin class of drugs like caspofungin, mycofungins are also the new class of antifungal. By the way, they are available. I think I have seen caspofungin. It is available locally, but you will get them from high facility. Yeah, they are usually given intravenously on the daily basis. So you can actually consider to give them in very severe condition. Yeah, fortunately, they might be even expensive cost-wise. So this is normally the options of treatment for refractory cases of oral candidiasis. Okay, now let me take you through about the treatment of esophageal candidiasis. So most of the time, esophageal candidiasis usually require systemic antifungal treatment. And because of the risk of morbidity, there is significant morbidity associated with esophageal candidiasis. Most of the time, there is a need of aggressive treatment. So the first line treatment modalities, even in our setting, is fluconazole between 200 to 400 milligram orally for 2 to 3 weeks. That is the recommended regimen in managing this condition. But of course, we do have second line alternatives such as itraconazole, posaconazole, and voriconazole can also be used as a second line in the management of esophageal candidiasis. Okay, also, if echinocandin or amphotericin B can also be used an alternative if the patient is not able to tolerate oral therapy, we can actually consider intravenous administration of either echinocandin or amphotericin B can be considered in case of even resistance or refractory condition. Okay, then remember, esophageal candidiasis is very common in HIV patients. So if the immune system is compromised, if the immune system is actually compromised, now, and if the condition is actually very severe and recurrent, sometimes you are supposed to give maintenance therapy for this condition to prevent the possibility of relapse. This one is actually very common. So this is what I have said before. You have to give for a minimum of 2 to 3 weeks to treat esophageal candidiasis. Either fluconazole, amphotericin B is an alternative, but fluconazole is the front line in the management. So in case of refractory cases, the recommendation is you give them for a minimum of 3 to 4 weeks, either itraconazole, voriconazole, or caspofungin can also be given as an alternative in case of refractory cases, but the duration of treatment is a bit longer. If the patient is not responding for fluconazole, you have to consider itraconazole, but the duration of treatment should be a bit longer. That is how we are going to treating refractory cases. Then how do we assess the outcome? That is known as the patient monitoring or outcome evaluation. So the patient should notice symptomatic relief within 2 to 3 days of initiation of therapy, but most of the time complete resolution requires like 7 to 10 days of treatment. However, they are supposed to continue the entire course of therapy. That is recommended, otherwise there is a possibility of relapse. Okay, then the course of oral azoles are usually associated with GI upset. However, if the course is actually longer than 7 days, now there is a possibility of hepatotoxicity as well as there is a drug interaction. Remember, almost all azole antifungals are cytochrome 450 enzyme inhibitor, which is the major enzyme responsible for metabolism of drugs. So as a result of enzyme inhibition, they can actually increase the toxicity of the other interacting drugs. So you have to monitor also the possibility of hepatotoxicity for short duration, look at any GI complaints. For long, maybe look at any hepatotoxicity. Okay, how do we assess whether a drug is hepatotoxic or not? Like for example, the patient has taken fluconazole for 20 days and we want to check whether the patient is having any liver problem or not. What do we do? What do we do? Tell me.
Continuous liver tests.
What kind of liver test you are supposed to do?
ALT and AST enzyme level.
So why you prefer ALT and ST? There are several tests to assess liver function. So why you prefer?
Maybe because they are the main hepatic markers for any liver condition.
Okay. Any other? But all albumin is also like serum level of albumin, like liver in other liver enzymes are also markers of liver function. So why we prefer LT and ST? Any other person who can consolidate?
I know AST is more sensitive to the liver.
Okay. By the way, it's not ACT which is more sensitive, it's LT, which is actually more sensitive marker. But however, when there is an acute damage, remember LT and AST, they are known as transaminase enzymes, LT and AST. Those are an acute markers of liver damage. So if you want to know whether the liver is actually injured because of drugs like anti-TB drugs, usually it is very notorious to cause like the isoniazid, the rifampicin, they're actually very notorious to cause hepatotoxicity. So if you want to know whether there is like a damage of like an acute damage in the liver parenchyma, do ALT and ACT. But ALT is more specific, but both of them are acute markers of liver damage. But if you want to check whether the liver is actually damaged because of maybe long-term damage of the liver, like in case of like alcohol, in case of hepatitis B or viral infection, there is a possibility of long-term liver damage. So in that condition, do like the synthetic functions of the liver, such as albumin. Look at the serum albumin level. Look at the protein level in the serum. So those are like the chronic marker. So they will tell you like the liver has been damaged chronically. Yes. For example, in case of like alcohol, look at the GGT and look at even the ratio of ACT and ALT. I think Lani will take you through about the GI disorder. Are you taking in this semester or next semester? GI disorder, GI and respiratory.
This semester.
Oh, okay, so fine. So you will actually digest in detail like alcoholic liver disease. When does alcohol actually cause liver cirrhosis? What is the risk of actually taking alcohol? So you will actually, what are the markers of actually alcoholic liver disease? So those are the kind of information we are going to like equip with at the clinical practitioner when you're actually working in the hospital setting. So there are different markers for liver function test. There are several, by the way. Even you are going to look at the clotting factor, prothrombin time. So those are even assessing the synthetic functions of the liver. So if you want to check chronic damage, look at any marker that can actually assess the synthetic functions of the liver. If you want to see acute damage, look at acute markers of parenchymal damage, LT and ACT level, and most of the time, 3 times from the upper limit should be elevated. Okay, especially with drug-induced toxicity, we are going to look at it LT and ACT. Okay, then in a patient receiving prolonged therapy, like lasting more than 3 weeks, there is a need to monitor with a liver function test, specifically for azole antifungal class of drugs, because they are actually notorious to cause hepatotoxicity with long-term use. Okay, so this is all about esophageal as well as oropharyngeal candidiasis. So if you do have any question, you are actually welcome. Any questions so far? Any question? Okay, now, Now, in the next 20, 30 minutes, I will take you through about mycotic infection of the skin, hair, and the nails. Those are actually very common superficial fungal infection. So when you look at the global epidemiology of cutaneous mycosis, it usually affects like 20 to 25% of the global population, and the usual pathogens are dermatophytes. So remember, by the way, dermatophytes are actually like a class of fungal, superficial fungal infection, and mostly they love normally the stratum corneum areas of the skin or any body parts that is actually having keratin tissue. They like keratinized tissues for growth and causes further infection. So in general, those dermatophytes are classified by the general trichophyton, epidermophyton, microsporin. Those are the most common dermatophytes that can actually cause the skin infection. So less frequently, infection is caused by the non-dermatophytes known as malassezia fafa. I think this one is known as tinea versicolor. It's very common, by the way. It's very common skin infection. You will see like a ring lesion in the bodies, but most of the time they like the trunk and the neck areas. I don't know whether you came across malassezia fafa or tinea versicolor. Anyone who came across with this kind of fungal infection? They are very common. Tinea infections are very common. Anyone who came across this kind of fungal infection? Or I show you the image. Let me show you the image. Not this one. Is there anyone who came across this kind of fungal infection? So this is like the dermatophytes. They actually causes either hyperpigmentation or hypopigmentation in the scaly patches, characterized like pityriasis versicolor. So it is known as tinea versicolor, which is caused by malassezia species. So it is very common. I don't know. I have encountered several patients who is having this problem in my country, but I don't know about in Kenya. Okay. Okay, fine. So most of the time, those dermatophytes are the one that actually causes skin infection. But remember, they don't penetrate, but they're actually causing infection on the skin or hair or maybe in the nails. Yes, either fingernail or two nails. Okay, so most of them are dermatophytes, but sometimes can be caused by non-dermatophyte species known as like the malassezia species and also Candida species. Okay, dermatophytes have the ability to penetrate keratinous structure of the body, like that is the hair and the nail and the skin. They don't know, they most of the time they don't actually go deep. They usually have the ability to penetrate the keratinous structure of the body. That is usually the layer of the stratum corneum of the skin. Remember, tinea infections are superficial fungal infection in which the pathogen usually remains in the keratinous layer of the skin or nail. That is why they are called tinea infection. So when you say tinea, it's a fungal infection mostly invading the keratinized tissue of the skin. So why tinea infections usually do not involve the mucosal membrane like Candida infection, but they Candida like the moist environment. So you don't really see Candida infection on the skin. It's very, very rare, very rare. So if you see any skin fungal infection, that is most likely dermatophytes because Candida normally likes moist and warm environment. Bacteria infection likes more keratin layers of the skin. So you will see them in the foot, you see them on the palm of the hand, you'll see them normally on the skin. Yes. So they don't usually have mucosal involvement because dermatophytes usually likes keratinized tissues to grow and develop. They normally like keratinized tissues. That is why they are not actually affecting the mucous membrane. Okay, then those infections are named for the affected body parts such as like the tinea pedis. When it is affecting the feet, we call them tinea pedis. When it is affecting the groin area, we call it tinea cruris. When it is actually affecting the whole body, we call them tinea corporis. Okay, so what is very typical with tinea infection, I don't know whether you have seen it before or not, they are usually known as ringworms because they do have typical characteristic lesion known as circular lesion. You will see like circular lesion like this on the top of the skin or even in the palm. That is why they are known as ringworms. They are known as ringworms because of their circular lesion. So that is how you are going to identify them. Okay, then tinea infections are they are actually the second after acne in terms of like skin diseases. They are actually the second most common skin infection. But from the most common tinea infections are the pedis, corporis, and the cruris. Those are the most common. But among those, tinea pedis are the most prevalent cutaneous fungal infection. Because of actually, especially it's very common in men because of the kind of like shoes we are actually dressing every time. Like the kind of shoes we are wearing is actually the risk. So that is why hygiene is very important to prevent tinea pedis. What I don't like, the superficial fungal infections are, it is very hard to eradicate. It is very hard. Sometimes even with long-term treatment, you can actually then the moment you stop the treatment, it will actually keep silent, then it will come back again after maybe after several months. So that is the major problem with fungal infection. Then, as I mentioned before, fungal infection of the skins are caused by primarily by dermatophytes. That is what I said. And with tinea infection, the causative dermatophytes they usually invade the stratum corneum without penetrating into the living tissues, and ultimately they actually causes localized infection. So stratum corneum is like the uppermost layer of the skin. Yes, the uppermost layer of the skin is known as stratum corneum, and most of the time they usually reside and cause infection on that part of the skin. So, what is the primary mode of transmission? So, most of the time, the primary mode of transmission of these tinea infections are usually direct contact with other person. That is the most common. So, sometimes when you are actually sharing shoes like slippers, there is a high risk of transfer. Is very common. Then, when you contact them, now what will happen? The dermatophyte will attach to the keratinized tissues and ultimately leads to thickening of the cell. They bind, attach, then thickening of the cell. So sometimes, despite the infection is actually localized, but sometimes because of they can when you are actually itching them, it causes like ulceration and it can increase the risk of bacterial superinfection. Yeah, like the local flora of the skin can actually even cause super infection. Okay, then what are the possible risk factors of this condition? What are the possible risk factors of tinea infection? Prolonged exposure to sweaty clothing, then maybe sedentary lifestyle if you don't maintain your hygiene, warm and humid climate, using public pools, the skin trauma like walking barefoot, poor nutrition, immunocompromised, impaired circulation. Those are some of the possible risk factors of tinea infection. Then how do we treat? How do we treat them? That is very, very important. So the goals of therapy is to provide symptomatic relief, resolution of infection, and preventing of the spread. Those are the most common goals of therapy. But generally, when you are actually treating superficial mycotic infection, make sure you keep the infected area dry and clean as much as possible. Then we can actually use topical agents are generally considered the first line therapy for infection of the skin. Most of the time, we usually give topical creams. However, when a patient is actually having very severe infection, we are supposed to use oral therapy. We are supposed to use oral therapy. So let's see about the treatment of each fungal infection of the skin, tinea pedis. So this is the most common, as I mentioned before. It is also known as like athlete foot. It's very common usually in hot weather, yes, and such as even use of very occlusive footwear. Those are the most common causes of tinea infection. So this is how it looks like. And you see normally like this is how it can actually even peel the stratum corneum part of your skin. So this is how it looks like when a patient is having. So like you can actually even see how the sole of the feet are actually affected severely. And it's very hard to treat. That is a major problem. So tinea pedis, they are having different presentation. You will see sometimes between the digits, like this. You will see this is the most common presentation. And sometimes with the moment the patient is actually itching them, like the moment the patient is actually, they are very burning. So you have to actually, like they're actually itching sensation. So then it can actually be causes some kind of irritation. So this is the most common presentation. There are also other form, like in the plantar surface, we call this one is this kind of presentation. There's also this presentation. Sometimes they form vesicle, but this one is the most common form of presentation of tinea pedis. Okay, then if they disturb the skin integrity, now they can actually even cause bacterial infection, cellulitis, bacterial infection of the skin. But this one is when there is disrupting the integrity of the skin, it can actually cause a superficial bacterial infection. So how do we treat athlete foot or any fungal infection of the feet? Topical therapy, 2 to 4 weeks is usually adequate for mild infection. When a patient is having mild infection, maybe clotrimazole cream twice daily for 2 to 4 weeks. Then maintain dry and they are supposed to actually wash before their menstruation. Then maintain their hygiene. That is the front line in the management. But if there is severe infection or involvement of the nail, then that is there is a need of oral therapy. I will come later when we're discussing about infection of fungal infection of the nail. Most of the time, nail infection is very hard, like it is very hard to actually penetrate. So most of the time there is a need of oral therapy. I will come later why. So there are several antifungal agents we're having, by the way. Yes, the terbinafine, yeah, one is also available. We also have clotrimazole, miconazole, the topical, even ketoconazole creams. We are having several azole topical antifungals. Like for example, clotrimazole, which is a widely available one, twice daily. But remember, 2 to 4 weeks are usually recommended. Ketoconazole is also available. Miconazole is also available. Terbinafine is also available. In fact, this one is the most widely available topical antifungal medication in our local market. So this is the whole list. You might get in different facilities, but the facilities I visited, those are the most common the most common claims you can actually get. You give them twice daily, then you monitor. Okay, so then I think for today, let us stop here. Any question? Any question? Okay, fine. So I think if you don't have any question, you can leave